Hi everyone to Advanced Echo teaching for the week, and we're going to talk about pericardial diseases. And I guess the main pathology we've got to talk about there for talking about pericardial effusions and tamponade and constrictive pericarditis are the big ones to know about, and have been and will continue to be asked in the DDU exam in some format or another. Okay. So we'll start off with a pretty standard question. So Rishi, which one of the following patients is in cardiac tamponade?
So cardiac tamponade would be a clinical diagnosis.
Mike.
Everyone. It
That's
supported by
fantastic.
echocardiogram.
Beautiful. So you can't say whether they're in tamponade. All you can say is they've got differing sizes of pericardial effusion. Very nice, very nice. So absolutely, sorry to be a trickster, but you're, of course, the echo is useful for supporting the diagnosis of pericardial tamponade. It doesn't make it. So it is a clinical diagnosis. And I guess the classic one that we're always learning about in medical school is the shocked patient with a raised JVP. In my clinical experience, that's not always the case, I've got to be honest. In my clinical experience, if you're getting to a shocked patient with tamponade, it's often sort of getting towards a pretty dangerous state of affairs, and there can be sort of peri-arrest, and absolutely that's fairly obvious. But the biggest one for me is the shortness of breath. And someone who is short of breath that is worse when they're lying down is someone who might be sort of getting towards that state of shock. And again, I have in my mind the idea that you don't need to be hypotensive to be in shock. You don't need to have a raised lactate to be in shock. It's a clinical diagnosis, and therefore, shortness of breath is a big sign for that. So maybe I could just say that if you're unwell with some shortness of breath, worsening lying down flat, with echo features of tamponade, supported by echo features of a pericardial effusion with some echo features of tamponade, that is someone who I absolutely say needs to be drained. And we'll show some examples of how I find that not always straightforward, but how I'll do it in my clinical practice. So the things that we are looking for, and we'll show examples of in these cases as we all go through them, we obviously need to see an echo-free space, and we need to make sure that's the pericardium, not the pleural space. We need to make sure that if we think that there's something, exudate versus transudate, if we think it's some form of exudative process, we don't mess that up for someone, for example, who might have a pericardial fat pad. So we've got to make sure that we're not calling an echo-free space filled with something when it's actually, a bit of fat. Tamponade is where you have pressure outside of the heart in the pericardium that is greater than a pressure that's inside the heart, and that's why you get chamber collapse. And the chambers that are going to collapse are the ones with the lowest pressures. And as you can see from is it a Wiggers diagram? Yeah, Wiggers diagram. That the pressures that you're going to get, the pressures that are often the lowest in the heart are the right ventricle and the right atrial pressures. So those are the chambers that often go first. And they go when they are in their lowest pressure. So particularly the right atrium, that's during ventricular systole, and with the right ventricle, that's during right ventricle diastole. If we're dealing with pressure differences across the pericardium, if someone is hypovolemic and they've got a collapsing IVC, that means that they're more likely, those pressures are going to be lower, particularly in the right atrium and the right ventricle, because you've got less amount of blood around in the system. And this can give you something called pseudo-tamponade, which we'll go through. And pseudo-tamponade is where you have these features of chamber collapse and an echo-free space around the heart, but the IVC is not dilated. Okay. And then the last thing we're going to discuss is the sort of the physiology of the tamponade, where you've got these raised pressures and what that does to blood flows in the heart. So particularly looking at increased mitral valve inflows with expiration, and with inflows, increasing flows across the tricuspid valve. Okay. So I'll just spend a little bit of time. That's sort of the overview of probably the majority of this talk, to be honest. So just keep all of those 4 things in mind, because those are the things we've got to look for, and you're expected to know and kind of regurgitate during the written exam, and obviously know about it for the clinical. Okay. Let's talk about the echo-free space around the heart. So you do not have to have a big effusion to cause a tamponade, but if that's got to happen though in an acute setting. So the size does not mean that you're going to have a pericardial effusion or a tamponade or not. A lot of those pictures that I actually showed you in the first scan there of some quite large effusions, those were all taken just on standard people who walked into our echo lab. This, if you have a uremia from renal failure, if you have cancer, if you have, chronic pneumonias that can lead you to pericardial effusions. All of these things come on over time, and you can tolerate them very nicely if you do it over a long period of time. And that's because you're trying to get to this stage. What is causing that tamponade is where the pressures in the pericardium are greater than inside the heart, and you get that chamber collapse, which stops blood flowing around the heart. So it's an obstructive form of shock, as I'm sure you all know. If you do that acutely, though, that's a very different story. And for example, some of those cases we discussed last week with the guys who've got dissections, for example, they had very, very small amounts of blood in their pericardium, and that caused tamponade physiology and literally taking out 10 mils of blood, and those guys come back from the dead. So if it is a rapid, acute accumulation of fluid, you do not need a lot of fluid to cause tamponade. And that's opposed to a chronic, slow accumulation of fluid where you can have up to a liter of fluid around the heart. You can often have echo features of tamponade, but you do not have physiological features of tamponade. Okay. As always, please stop me if I'm talking rubbish at any stage or you want to ask a question. So we kind of grade severity based on very nebulous measurements. So we're taught to always measure them at end systolic separation only, so that you're trying to get a sort of maximum diameter. We're looking at that echo-free space, and we talk about 10 and 20 being the markers of small or mild, medium between 10 and 20 millimeters, and large being greater than 20 millimeters. And we're measuring those. Excuse me, I'm reading it wrong. We're measuring that echo-free space end diastole. So you're not going to be capturing someone's heart moving together. It's always at end diastole, so that this heart is, the biggest space that possible, but during end diastole. Okay. So as you build up this fluid, that is obviously going to increase the intrapericardial pressure. When that exceeds the pressure that's in your right ventricle, for example, that's when you are going to start to impair filling. And when you are going to start to impair filling, that means that you're going to get increase in venous pressure, and that will cause you to have that fixed dilated IVC. And when you've got that impaired diastolic filling, when it gets great enough, you are going to cause collapse at end systole of that right atrium and early diastole of that right ventricle when those chambers are at their lowest pressures. That leads you to obstruction or stops the preload to the heart, and that's when you're going to get your low stroke volume and your reduced cardiac output, and that's what gives you the impaired cardiac output and signs of shock. Okay. Just a little bit on the Doppler features of the tamponade that you get. Those pressures around the heart when you've got a pericardium that's full of blood are transmitted to the heart much more effectively, so that you don't have a buffer almost. So you get this exaggerated response to normal physiological heart-lung interactions. So that means that if let's take inspiration first of all. As you breathe in, you generate this negative intrathoracic pressure, which means that you help that pressure difference between your IVC and your right atrium as you open up the lungs, and that sucks blood in. So you get increased preload coming towards the right ventricle. And because it's exaggerated with that negative intrathoracic pressure because of the fluid that's in the pericardium, that means you get an excessive amount of flow of blood through the tricuspid valve. And they classically talk about 40% difference. So normally we see little variations of change in the tricuspid valve in the RV inflow, but that's massively exaggerated during tamponade and constrictive physiology. What that can do is it can cause a septal bounce or ventricular interdependence, and so that interventricular septum can get pushed over and towards the left. Okay. And in turn, therefore, that can also look at a bit of a decrease in your LV inflow. All right. So to summarize again, inspiration, negative intrathoracic pressure, increases the pressure difference between your IVC to your RA. You get increased blood coming into the right ventricle, and that's 40% increased flow, pushes the interventricular septum over, reduces flow on the mitral valve. The exchange then happens with expiration as you increase your intrathoracic pressure, reducing the preload to your right ventricle, increasing the preload to your left ventricle, and you're going to get increased mitral inflows. And they're classically at 25%. So these changes between the left and the right, exaggerated flows between them, and this is where pulsed wave Doppler and your apical four-chamber view down each of those left ventricle and right ventricle can help make the diagnosis. So here are a couple of examples. You're going to try and measure an E wave during inspiration as in having more than a 25% change in variation. So this is the opposite to what you'd expect to be seeing in the tricuspid. I'm sorry, I don't have one with the respiratory flow pattern in there. But you can see this big change. So as during inspiration, you'd be getting this increase in flow, and then expiration, it goes down. And that's different with the mitral valve. Okay. I think they do, it sort of depends on the guidelines. I've heard people quote things like, 35% and 60%. I think the bottom line is no one's going to pass a fairly for any of these things. European and American guidelines are a little bit different, and just an exaggerated response to heart-lung interactions, I think, is all you probably need to remember. Okay, so let's talk about pericardial versus pleural effusions. Hey, how do you tell the difference between a pericardial effusion and a pleural effusion? Because I've got a bit of both on that picture there.
In relation to the location of the descending.
Beautiful. So I hope you can you see my marker online? Thanks. So you can see down in here, you've got the descending aorta. We've got the visceral and parietal pericardium in there, and they enter behind the descending aorta, as opposed to a pleural effusion, which comes behind it. Okay. So pericardial effusions are often smaller. Oops, sorry, excuse me. Pericardial effusions are often smaller. They're circumferential, though not always, but they are in front of that descending aorta, as opposed to pleural effusions, which can be much larger, as you can see here, and they extend behind the descending aorta. All right, Michael, how can you tell the difference between a pericardial effusion versus a fat pad?
Well, I guess it can be really tricky, but essentially a pericardial effusion, you might see it extending around to the deepest surface of the heart as well, behind the left ventricle, whereas a fat pad should only be there on top of the right ventricle. And the pericardial effusion should be more of an echo-free sort of space rather than a fat pad that you can see a bit of speckling. But I guess sometimes it can be really tricky to tell.
Yeah, and also I'd argue that with those speckles that you can see in there, they move with the heart. All right, nice. All right, let's go through a couple of cases. So those are the echo features you got to be able to pick up on. So just to summarize really quickly, it's an echo-free space. You got to say whether it's small, moderate, or large. You're looking for free wall collapse, particularly the right atrium and right ventricle. So right atrium during ventricular systole and right ventricle during ventricular diastole. We're looking for exaggerated heart-lung interactions, so exaggerated flow. So during inspiration, when you're not intubated, inspiration, increased flows across the tricuspid valve, more than 40%. And then during expiration, with the mitral valve, 25%. Okay.
RA collapse, is that diastole as well? Because diastole, it says
right atrial diastole.
Right atrial diastole.
So yeah, sorry, I always think about diastole being ventricular, so I always say right ventricle systole, but it's right atrial diastole. Yes, whenever the pressure's at the lowest, and yeah, I always have to kind of work my way backwards. Yeah. 84 women admitted of a biventricular pacemaker. We've all been here with this story, I'm sure. So previous dual chamber pacemaker, slow functional deterioration. They attempted to enter a biventricular pacemaker under GA, found a very tricky procedure, progressive hypotension and shock in theatres. They commenced adrenaline and abandoned the procedure and admitted her to the ICU. And of course, we went on and did an echo. Rishi, do you want to tell me about some of these features? How about you take us through this case?
Yeah. So
They get gradually harder, you'll be glad to know. So Haywan and Michael, go yourself.
we are looking at a combination of parasternal long axis and short axis views of this poor patient. So looking at the top left image, looking at the parasternal long axis view, there is commenting on the pericardial effusion, the pericardial space per se. There appears to be a homogeneous anechoic collection in the pericardial space, more in the dependent region. In addition to that, the LV function appears reduced. LV
doesn't it just?
LV size appears a bit hypertrophic to me, but I need to measure it.
Okay.
Exact. Can't comment more on the chambers, but RV appears normal size and contracting well. On the short axis view, again, the LV appears quite severely dysfunctional.
Quite severely dysfunctional?
Is as severe LV dysfunction.
Thank you very much.
And with no evidence of any RV dilatation.
Nice. What about the pericardial effusion?
So
Talk to me about that.
Again, along the posterior to the inferior wall, there appears to be an anechoic homogeneous collection.
Yeah, you said just posterior to the inferior wall.
It's situated anteriorly as well.
Yes, so it's circumferential.
Circumferential.
Yeah, I agree.
More in the dependent region, mostly from gravitational. So likely and the measurement along the last image on the fourth side shows a distance of around 1.9, which will rate it as at least moderate pericardial effusion. So we are looking at a moderate pericardial effusion developing immediately.
Brilliant. And when we see a pericardial effusion, the next thing you're going to tell me is whether you think there are echo features of tamponade.
So echo features of tamponade will be the diastolic collapse of RV and diastolic RA collapse, RA diastolic collapse. And with IVC, we have to see if it is fixed and dilated, along with also at the hemodynamics of the patient. What it has done.
Okay, there's a microphone. I hope that does that make it a bit clearer from the. Can you hear us a bit better, Michael? Yeah, cool. So we're just going to put some mics on. It might just help it when we're talking around the room. Beautiful. So we're looking for right ventricle free wall collapse. Do you think we got any collapsed here? It's a bit tricky. Maybe if I can just pause it. Oh, no, I can't see the. Oh, never mind. But yeah, we're looking for RV free wall collapse during diastole and an RA free wall collapse during systole. Maybe I can try it a bit better with this. Okay, so we're looking for RA collapse. That's systole. Do you reckon you can see any? Yeah, right. And this is what these cases are all about, because they're all real cases. And for love or money, the story that you get very much sounds like, someone who's had a tricky procedure. We've now got a new pericardial effusion. And I still find it hard to look at RA and RV free wall collapse, right? I still think it's hard. I think we're seeing it just here. Just keep looking at that RA free wall collapse as I go back between systole, and I think you see a little bit of a buckle.
Yeah.
All right. Obviously, the more it buckles, the more likely it is for tamponade, and it's the same with the RV. I guess what I'm trying to say is I think it's tricky. You've got to look in different views, because I think it looks much more obvious suddenly when we're looking in these other views that you can see this RA, which I think is collapsing up here and down here. It's not easy though, right? And sometimes our patients, it's not quite as easy and straightforward as it sounds. And this is where this Doppler stuff can come in useful. I think if you're seeing some of this exaggerated flow pattern, this is just another tool. I often find that maybe not one of them is useful in isolation, but then putting it all together with the clinical story is what it's all about. You know, you've got a story of someone who's got then a decent sized pericardial effusion. It's probably come on acutely. We've got lots and lots of exaggerated flows going through the mitral valve and tricuspid valve. I think we've got some free wall collapse. It's a bit hard, but with the clinical story, it's absolutely someone who we should be looking at training. Yeah, nice. So I think it's okay to be sitting on the fence, but you just want all that information available. So that's where these Doppler flow patterns are really important. I wonder whether there's a bit of blood that was sitting around here. We sometimes can see a bit of a homogeneous appearance. If someone has had an acute bleeding episode from a pericardial from a failed pacemaker insertion, you expect there to be some blood that's sitting in there. Maybe, exactly right. And maybe we can see it a little bit better in this subcostal view. And so particularly when you're starting to see echo free spaces behind it, that's where I start to think that this is got a thrombus effect. Okay. What's going on here? Yeah, very nice. So you're just starting to see a little needle coming in. So from the subcostal approach and injecting some bubbles or a little drain in there, and that's trying to confirm the position of the drain in the right spot. So all I do with this is when you think your needle's in the right spot, you withdraw about 1, maybe 2 mils of the pericardial fluid. You can put a little bit on the dressing to make sure it doesn't clot. I think that's a pretty old school way of doing it. But I take a mil, I then draw up about maybe even just half a mil of air. I don't agitate it, I just squirt it straight back in. And the pericardial fluid with the air makes this quite satisfying, bubbles appearance. And this is what it looked like after the drain had gone in. Okay. So I think echo is quite nice here, trying to show and sort of monitor the effects of before and after a procedure and helping guide the procedure as you go. And we'll talk about that again in a sec.
Why don't you agitate it? Why don't you agitate it?
Because you don't need to. I often find it quite hard because I often do this like as a one-person technique where you can guide your entry sites with the echo probe. You don't use it for live drainage. I use it to line up where I'm going to put the needle.
Yeah.
I then put the thing down, I poke in my needle, I get something back. Yeah. And then if you're doing it with a one-handed technique, I sometimes find it hard if you've only got, we've got, for example, in this one where we're doing a subcostal approach, we've got a maybe 2 centimeter landing zone, about 8 centimeters of liver to get through. And so if you've got a short landing zone, where I've got into trouble is where you start losing the needle, because you're obviously pretty nervous about doing this, because if you go too far, you start sticking your needle into the heart, and that's always pretty scary. So I generally find you've got to hold on to that needle pretty well. Unless you've got another person there agitating the saline for you, it's a bit tricky. And often it just works well with just a little bit of pericardial fluid. I'm still not actually sure of the physics of why it lights up so well when you squirt it back in. Someone was saying something about as you inject it through the metal needle, it picks up some sort of electrical charge or something. I don't know, but it does work nicely, and you just don't need to agitate it. Okay. I've done both, and I just found it works just as well with a bit of pericardial fluid. It doesn't work well if you just have water, though. You can't just squirt water in and it works. Then you'd have to agitate the water. Yeah. But with just a bit of pericardial fluid, it works much better. Sure. Nice. And you can see the pacing wire is just the old pacing wire that they've got in there already. All right, case 2. Hang on. This is a cracker. So, a charming 37-year-old man who is an intravenous drug user. He'd recently come into hospital with a strep bacteremia and suspected PE. He'd had symptoms for 3 days of shortness of breath, worse on lying flat, with chest pain. Came into ED with new track marks. He was afebrile, a bit of hypotensive. He had a CTPA done because there was a previous suspicion for a PE, and it showed he had subsegmental PE. So, you know, did he have a intermediate high risk PE or not? We were trying to figure out. So he came in to see us. He was afebrile on mild noradrenaline requirements. He had a heparin infusion running against the subsegmental PE and a mild AA gradient.
Aristotle on axis view. Again, there's a large anechoic space circumferential to the heart, suggestive of pericardial effusion. LV is hypodynamic. I can't appreciate any right ventricular collapse, so I need a bit more images.
Yeah, fair enough.
Yeah. So this must be subcostal short axis, is it?
This is it a subcostal short axis? It could be, can't it? Because it looks a bit off axis, doesn't it?
Yeah, short axis.
Yep.
Fine,
It's a short axis. Yeah, good call.
Again, I can't really appreciate a large pericardial effusion here, or maybe in that.
Yeah, he's got some anteriorly there, doesn't he?
Sure.
I think
Okay,
that's an
yeah,
echo-free
so-
space we can start to see around here.
Yeah.
And we saw it in one side, right? So you saw it up there.
Yeah. And,
So I think we're seeing it there and starting to see it in this recess down here.
yeah,
What else can you see?
but there's also abnormal septal motion,
Mm.
well, D-shaped septum really.
Yeah, is that what is that all through the cardiac cycle?
No, it happens during systolic septal flattening. And also the
Okay, so let's just go through it. So that's systole, D-shaped, there's a bit in diastole.
okay, diastole.
Yeah.
Yeah.
And then do we see it so much there?
Here it is.
Yeah.
Which is mostly during diastole.
There wasn't as much then, was it? Let's have a look.
Yeah, I mean, it appears to start end systole and
Yeah.
continues throughout the diastole.
I was also trying to, I guess one of the things I was also trying to stretch out and show in this one is I think it looks a bit worse in maybe the third cardiac cycle compared to the first. I agree. I think we're seeing some, I think it's probably some systolic and maybe some diastolic collapse that we're seeing there. But it does look worse during one cardiac cycle compared to another. And I wonder whether there's a respiratory and evidence of respiratory interdependence going on.
Yeah.
Okay. What else are we seeing? And, you know, remembering back to the history that I gave you.
I mean, I'm worried about infective endocarditis.
Yep, sure.
But I can't see any obvious. I mean, but one of the salient features is like RV is enlarged. And
Nice. Okay. So why is the RV enlarged?
I mean, it also looks hypertrophy.
Yeah, good call. Yeah, very.
Just chronic process. So unusual in a 37-year-old.
Yeah, but he is a bit unusual in the fact that he loves drugs.
Yeah.
Or maybe not unusual, but yeah, he's got some reasons to potentially have chronic thromboembolic disease, I guess.
Sure. Oh, yeah. Yeah, but I can't really put all of them together, to be honest.
Yeah, absolutely. So it's tough, right? But he's definitely got some, you know, if he's got a pericardial effusion and you've got chronically elevated pulmonary pressures, or you've got some reason to have a dilated right ventricle,
Yeah.
sometimes you're not going to get RV free wall collapse.
Sure.
That doesn't mean that you can't have tamponade,
Yeah.
because you can squash other places, such as the right atrium, indeed the left atrium. And looking back at this picture here, you can start to see, sorry. You know, I don't think we're seeing it just yet, but it's not beyond the realms of possibility to start to think that the left atrial pressure might actually be relatively low compared to the right-sided pressures. And you can still get tamponade despite a thickened, dilated right ventricle. And one of the features that can make us worried that potentially we're starting to get problems with tamponade physiology might be this interventricle interdependence.
Sure.
Okay, so again, we're looking for exaggerated transmitral and transthoracic flows. If you've got a dilated right ventricle from pulmonary hypertension, it can start complicating the picture, is what we're trying to get at on this one. So a couple of days later, we were keeping an eye on him. We did not drain him straight away for all those features that you said, but this is when he started to become unwell and got intubated. This is what then happened a couple of days later. What's going on here?
Again, now there's a heterogeneous, the pericardial effusion appears is large and heterogeneous. And again, RV is hypertrophied and dilated, but I think the most of the collapse and hemodynamic effects on the left atrium.
Yeah.
And potentially even in the LV. I mean, left atrium, yeah, I think there is systolic collapse there.
But I agree, and so we'd been holding off intubating this guy because holding off draining this guy originally because we were arguing about all of these features. Were we seeing signs of tamponade? He was short of breath, worse than he was lying down flat, but he was on a smidge of noradrenaline, and so we ummed and ahed about it for a day or so, I'll be honest, when he was clinically looking relatively stable. But we went back, and this is what we then found. This is not bubbles. The reason I was asking you about it on the last one is because this looks fairly similar, doesn't it? It looks like we put bubbles in it, but we have not gone anywhere near as pericardium. So what the hell is that? Pus. Man, this is a sign of a very nasty sort of exudative process that's in there, and that is pus. Okay. We absolutely were seeing these signs of these exaggerated inspiratory and expiratory responses that we were seeing from that you talked about from the left atrium, and this is what prompted us to go having a look further, taking into account that ventricular interdependence. I think it was maybe a bit more obvious on the other one. See the raised right atrial pressure, and this is after we'd gone in and drained some of this fluid. So I put those around the wrong way. And this is what we had in there. And what we grew was this stuff. This is the stuff that we pulled out of his pericardium. So it looks a lot like pus. And that was strep that he'd grown in his pericardium, which is fairly average, of course. Okay. So purulent pericarditis, I think, is even more scary than your bog standard pericarditis from other things. It's hard to treat, and you need to get on top of it early and obviously give the right antibiotics. So drainage and sending it off for cytology and for microscopy and culture, obviously.
Did he develop any features of obstructive?
Yeah, great question, and we won't go into it too much for this guy, but it's absolutely he could have done. He didn't. What he did start to develop was lots of fibrous changes in there. We actually found it really hard to drain him because he started to create pockets of pus in there. And one of the things they're suggesting in this article, I'm sorry, I forgot to put down the actual place that I got it from, was talking about the use of fibrinolytic therapy. So if you're going to be aspirating a purulent effusion, they talk about using echo guidance, but one of the things that they'd suggested in this was as soon as you start to drain it, that's when you need to institute this fibrinolytic therapy, in case this then goes on to develop lots of cobwebs. And that's exactly what happened with this guy, and he got into a whole bunch of trouble because we found it really tricky to drain it, and he had to go to surgery to have it done because we couldn't do it minimally invasively. So a really tricky kind of disorder, I think, this purulent pericardial effusions. Michael, I'll go this one. 56-year-old Syrian refugee with developmental delay, wheelchair bound. She had this hemangioma for several years that someone eventually felt that they need to try and deal with embolization. And unfortunately, that was extremely tricky. And she had some shortness of breath, tachycardia, didn't tolerate the procedure very well, and came to ICU because of persistent tachycardia. And that's why we did the echo. So she's just tachycardic. What do you think of all this?
So it's a parasternal long
You're on
axis
mute,
image of a woman. Am I? Can you hear me now? I'm unmuted.
Oh, hang on, are you on mute, or is it just because I plugged the mic in? Oh, hang on, maybe because I plugged the mic in. Hang on. Go for it. Speak now. No, it doesn't seem to work. You're all right, Cham. It might be my fault this end. Don't worry about it. I'll tell you what.
Hello?
I knew you were going to be perfect in talking about it. I can talk through this one.
Can you hear me?
I think it's me at this end. I think I'm having troubles with I think I'm having troubles trying to be fancy with microphones. No, I still can't hear you. Never mind. I will go through this one. So this lady, we can see a circumferential pericardial effusion. Looks about maybe 1.5 centimeters in size. It's in the moderate category. Little bit of maybe a bit of a bounce there during diastole potentially of that right ventricle, and we can pause it and try and roll through to try and see during diastole that goes there. I think there might be a little bit of a bounce. You see that little bounce there? That's during diastole. I'll come back on maybe a couple. So during end of T wave to beginning of QRS, a little bit of a bounce. A little bit of a bounce. Little bit of a bounce. Okay, so we've got some signs of right ventricle diastolic collapse. Short axis can really help with that, and you can often put M mode through it, but we can clearly see we've got some right ventricle free wall collapse and right atrial collapse in there, and a bit of left atrium potentially as well. So there's a still, ventricular systole, right atrial collapse. All right. I can't remember how big that is, but that looks to be about maybe 2 centimeters there. We end diastole, yes, we are. So maybe it's a large in some areas, particularly inferiorly. And this is someone who I guess you can say, for all your love of money, this looks like we've got some significant echo features of tamponade. But did she have clinical features of it? No, she didn't. She was just tachycardic. All right. We've got nasty inflow view changes during inspiration, excess flows across the tricuspid valve, echo free space, diastolic RV, free wall collapse, M mode can be really useful to look for your timings there. Another nice tip and trick if you're having difficulty with the timings. And this is what was going on. So she's got what's known as a pseudo tamponade. I think those echo features that we're seeing is because she is a bit hypovolemic, probably for some bleeding. I think that pericardial effusion had probably been there for some time, for some reason, which we've got to go and investigate. But is this tamponade? Well, if you've got a collapsing small IVC, that's something we call pseudo tamponade. And you can get out of trouble by giving these patients some fluid back. So I have to say, I can't remember whether it was this one or another case where I generally find that if you're, this can buy you time. If you give them some fluid and increase up their intravascular volume, you might change some of those echo features, but the fluid doesn't stay inside your blood vessels forever, right? It eventually comes out, and I generally find you have to come back 6 to 8 hours later and drain the infusion anyway. So, because I remember saying, "Oh, it's pseudo time, I'm gonna give some fluid," and went home, and then you're called at 2 o'clock in the morning, you're like, why don't I just do it when I was in the hospital? Yep. So, yeah, it can buy you time, I think, more than reverse the pathology. This next case, I think we went through this last week, so I might just slip through it again, of this charming intravenous drug user, 45-year-old guy who was found collapsed. He came into ED with a very barely palpable pulse, and this guy was shown to have this hemopericardium. You can see the blood that looks a bit similar to the case that Rishi just described from the lady who had that ballsed up pacemaker insertion. So this is acute blood. It's kind of got this linear homogeneous appearance and wriggling around like a worm. And that's acute blood that came from a dissection. And obviously we try to avoid sticking needles in these things unless you're peri-arrest, and this guy certainly was. And that's an example of a small pericardial effusion that just literally took out 7-10 mils of blood. And this guy, his physiology went from being moribund on 20 of quad strength NORAD and adrenaline or something ridiculous to awake, moribund, not moving, to being GCS 15, fighting people off. So it's a real phenomenon. And then you've all seen this. He had a horrible bicuspid aortic valve with a bit of regurg. He had a bloody horrible ulcerative aortic lesion which had led to some form of maybe I think it's probably an intramural hematoma that had spread all the way down and then leaked into the pericardium or something. There may have been a bit of excess fluid around it that had gone down through a small dissection flap. It was sort of a little bit hard to tell, but you had this thickened wall all the way around that may have been aortitis or an intramural hematoma. And here's the guy that went off and had the Bentley's procedure. Okay. You can see here, you know, a nasty ulcer sitting there in the ascending aorta just by the bifurcation of the pulmonary vessels. Yeah, amazing case. I might just say a couple of words on drainage. You've got three main approaches that you can do: subcostal, parasternal, or apical. I use echo to guide them all. Don't do it real time. I use the echo to help direct where you're going to stick the needle in. I then put the probe down and just advance along that track that I found with my echo probe. You do not use standard windows. So you're using the echo probe as like a lightsaber, if you can imagine it. So you imagine you've got your lightsaber on top of the echo probe and you're using it to shine your path in the heart to figure out where to put the needle. I don't want a perfect apical four-chamber view. If I'm going apically, I want my probe pointing in the same direction as my needle is. So I'll try and find that pathway that I can inject down. So instead of just looking for a 2 centimeter, you know, if it's a 2 centimeter wide pericardial effusion, I'm going to put my probe in such a manner where I can see, like, for example, a pathway right next door to the right ventricle. So suddenly I've got a 12 centimeter echo-free space. It might only be 2 centimeters wide, but it is much longer because I've gone off axis. And that's where you can see I did to one of these guys, see the direction of my probe. It's almost pointing towards his zippy sternum. So you're just pointing away from structures that can cause troubles. If I've shown an example here, so you can see where I entered into that guy's chest, and you're skirting along that right ventricle underneath, so away from the left ventricle. So next to the right ventricle, if you put a needle in the right ventricle, that's surprisingly okay. Putting a needle in the left ventricle or jabbing an LAD is not okay. And I think that's probably not words to live by, but try not to stick your needle in the right ventricle. But I don't know, I've done it a couple of times. I think what's really important is if you do stick a needle in the right ventricle, don't dilate it. That is not good. But if you can recognize where you are before you dilate, that's the important thing. Okay. And obviously here's some examples of injecting some of those bubbles back into the pericardium so that you can use it to confirm you're in the right place. All right, so I'll just move on to constrictive pericarditis next, but just to finish up on tamponade, you know, it's a physiological diagnosis, especially shortness of breath that's worsening when you lie down flat. Echo is going to use as an adjunct to your clinical diagnosis. Looking for an echo-free space, say whether it's small, medium, or large. You're going to look for RA or RV free wall collapse during ventricular systole and diastole, respectively. You use your Doppler, pulse wave Doppler at the tops of the mitral and tricuspid valves, looking for variations in inflow showing exaggerated heart-lung interactions. Okay. And then you can use it to help drainage. And just the mantra I have in my head as I'm doing it is I'm focusing on the needle, not the echo. All right. The echo is just to guide you. It's all about where the needle is. Okay. Just a few minutes on constrictive pericarditis. It's not super common. It's most commonly seen for us with things like infections in the pericardium, post-cardiac surgery, radiation, are particularly the ones that I think we see it with. You'll have a thickened pericardium. We're going to look at plethoric hepatic veins, and you see this septal change with respiration. So a bit like the tamponade physiology with these exaggerated heart-lung interactions, similar things can happen with constrictive pericarditis. The Doppler features are, oh, I have to show you now. The Doppler features is there aren't many echo parameters that are pathognomonic for diseases, but this is one of them. So annulus reversus. What's annulus reversus?
So usually in tissue Doppler, the lateral E prime velocity is higher than the medial
Nice.
velocities, whereas in constrictive pericarditis, because of the fixation of the lateral annulus, the medial velocities become large.
Very nice. Of course, you can see this if you've got, it sometimes happens with, nasty mitral annular calcification, if it's a bit weird, regional wall motion abnormalities. If you've got a pacemaker in there, it's accidentally, charging up the bottom part of the septum too much. So you've got to have you can't just say annulus reversus automatically equals that. You have to have the other clinical suspicion that goes with it. So a cause, that respiratory interventricular dependence, shortness of breath, and then annulus reversus is the final sort of stamp that goes with that. This is the example of the guy I was thinking I might be able to show you. So this is a guy who presented with chest pain and shortness of breath. He'd had pericarditis 1 month earlier, and he was tachycardic, tachypneic, worse when lying flat. He also had PEs, which he was on a heparin infusion for. And on examination, he was not well. And the big thing that was striking to us is this change from one cardiac cycle to another, particularly the respiration, of his change in his cardiac output. And you literally could feel as he breathed in and out the change in his pulse, pulse intensity. It was extraordinary medicine. He was not in a good state, lactates of 6 and oliguric. So this is what we found when we looked at him with an echo. And here you can start to see that we've almost got this thickened mass around the pericardium. This is it's got its echogenic space around the heart circumferential. And you can see the heart inside almost struggling to move, particularly in that anterior portion. And it looks like part of it are fixed. And when we start to look down at the pericardium, you get an idea that that might be fixed in that lateral ventricle and that medial annulus might be moving more. There's maybe even more visible there in that parasternal long. And this way you can see that that medial annulus is far greater than that lateral annulus. And we can see these respiratory, I think the echo image could have been optimized a little bit better here. But you can see that there is some respiratory variation that's coming on. Well, let's just see if we've got a, this is right. Yes, I can remember the story now. So we did this at the Echo Fellow of the Day, and we were all so excited about this. I was trying to get him to do this for one of his case studies. And unfortunately, I wasn't watching close enough when we were pressing go, because this guy was really unwell, and we knew we were going to have to do, once we made the diagnosis, we're going to have to do something just drastic for this guy. And so we didn't quite collect a long enough period to show the respiratory interdependence, but it was definitely there. I'm sorry, I don't have a nice picture of it. So this is what, is just pathognomonic for what looked like a constrictive pericarditis. But this was a little different because it was constrictive effusive pericarditis. And obviously this guy didn't do well, I'm afraid, but we were able to, the family wanted an autopsy to try and confirm the diagnosis, because he died very shortly after this, had a horrible cardiac arrest. And that was probably going to be related to a PE that he had. It was on moving. He was moving his legs and just had a massive cardiac arrest very suddenly. But why he was having that was a big thing for the family. And so we moved on and we did this autopsy down here with the pathologist. And this is what we found when he cut open the pericardium, is this awful looking effusive constrictive pericarditis that we can see here, and this sort of congealed mass that's sitting there around the heart. And and that grew. I think it was strep that it ended up growing. It was very nasty. So I guess that gives a bit of time for some questions there. So I guess in summary, I think the pericardial space obviously is an extremely important structure that we've got to be wary of. I always found that it was quite easy to learn from a textbook, and then when you take it into the real life, it is not easy at all. And so you've got to have your head screwed on right. The clinical integration with echo findings I find extremely important to link these two together, and using both 2D and Doppler features is very important. And that's that. Thank you for listening, guys.